this conversation that we're excited for you to be a part of is really about adding a new friend or a new relationship, a new surgical colleague into your procedure for anterior lumbar exposure, be it lumbar TDR or multi-level, single-level ALIF, whatever it is. I think there's a ton of value here, and we're hoping that just us going through some of the nuances of kind of where we started and what values we picked up from one another in this process, that maybe you'll be able to foster similar value out of your relationship with your current approach surgeons, or maybe even find a new one that is willing to have this conversation with you.
Something I took away very early on as we built our professional relationship was that collaborative sort of mindset. Coming into the operating room, both of us having skin in the game and both of us having a level of commitment to seeing the operation through. And I think that's probably been the most impactful thing on my career development, is kind of following that relationship through and then seeing it develop in other avenues of my practice as well.
Yeah, I think it is very difficult for surgeons who are used to being in charge and digesting, consuming all the risk, all the complexities, being responsible for every little step, and then having someone else jump in and participate in that, but also be kind of united in it at the same time. We did some access exposure in our trauma facility in Memphis where I trained. General surgery would come in, they do a big thoracotomy or for a lateral transthoracic approach, and there was never really a question, hey, do you think we need to take 2 ribs or just 1, or how much? You just kind of show up. And so there was really no conversation happening at all. I think it probably influences things differently than you might expect, because I'm comfortable in this procedure, anterior lumbar, for the same reason that I'm comfortable with anterior cervical exposure, right? So it's not just having a conversation about it. It is literally me understanding every layer of the access, every layer of how am I going to get there, where are the complexities, where are the complications, and you can't just have somebody tell you that. You have to be in it. You have to have your fingers in there, your hands in the wound. You got to see how it's happening, and also feel like you are comfortable moving the tissue and working with it as well. Even if we're doing it together, having the chance to be able to get in there and participate in it, and you not feeling like, hey, get your hands out, this is my part. I would never do an ACDF or whatever anterior cervical approach without fully being comfortable with the whole thing. And I wouldn't do any other procedure, brain or spine or whatever it is, without that same sensation. So I want to have that here, but if you separate the two components to the procedure, you totally lose that. Yeah, we can talk about it, but it's not the same. Sure. And obviously that relationship matures over time. So my hope is that when you see one of my cases coming on the books, and I haven't talked to you, because we don't talk about every single case because it's not necessary, but you also know what I'm thinking, that you've taught me what to look for, that I've gained an appreciation for the nuances, the complexities and complications that can happen from the access and exposure, and I'm drilling those into the patient selection part. How critical the access is to getting in and getting out with your instruments safely. So it makes 2 millimeters, 3 millimeters it's like a world of difference. I consider myself a minimally invasive spine surgeon, so whatever that means to whoever it is different, but minimally invasive, whether it's through the tube, I've done it all, I do it all, and you may too, but for me, it's kind of boiled down to how much do I need, how much exposure do I need, how can I minimize the amount of tissue trauma getting there. It's not just about the size of the incision on the ACDF. Really, it's about how long was I retracting, all those things. Very similar in the lumbar spine. How long are you retracting on the vessels, the the ureter or whatever it is. All those things play in to keeping something less invasive. And for me, the more and more I've grown in my anterior lumbar access, I would much rather have a wide incision, a wide funnel-like access point, if that's what it takes to get me a space where I can safely get my instruments in and out, where I'm not struggling to fit, a disc space spreader and a curette or a box curette or whatever it is at the same time. I want to just have access, because if I can't see what I'm doing, if I can't, when it starts bleeding or whatever, or retractor shifts or whatever it is, it makes things so much more difficult, and it's already taken a space. We're already very deep sometimes. I mean, even if it's a very shallow hole, it's still deeper than any other lumbar posterior spinal hole that, incision site that we're working through, and definitely in the neck.
I'm kind of glad you brought in the whole minimally invasive topic. I have my own beliefs about what defines minimally invasive in the access world. I think in the spine world, muscle sparing is right. It's a lot of that conversation discussion. There's absolute value in that. I think there's a balance, and it's finding that sweet spot. So I've almost kind of, in my mind, shifted my buzzwords away from minimally invasive to optimally invasive. Finding the optimal incision size, soft tissue mobilization, fascial release, all these things. It's finding the sweet spot so you're doing your operation cleanly, efficiently. Like you said, there's a downside to having retractors in for an hour or two.
This is going to shift the subject a little bit, but I've gone back to Australia, I've gone back to Germany since I've done my training, and the thing that's fascinating to me is how fast and how quick the combination of the spine and or access surgeon is going to transfer from retroperitoneal to even transperitoneal.
Right.
And that's a huge jump, which I can't even remember the last time we went transperitoneal, right? But optimal access, they're picking up more complex cases, expanding their indications, finding new ways to get what they want, rather than finding a reason not to do it. So if transperitoneal is the right approach at L1-2, below the renal artery, that's what we're going to do. And we might not even be thinking about doing that. But it really isn't, we can't fit everything. You can't do every lumbar spine decompression through a tube, because it's not right. Because it's not the right approach, because it's going to injure the facets, because it's going to take too long, because it's a redo, and it's probably not as safe, and all the above, right? Well, it's the same thing in the interlumbar exposure. If you're not having this conversation with your exposure surgeon, you're cutting yourself short on a lot of cases that you could be doing, and you're also setting yourself up for a lot of frustration when you show up for a surgery, because you're not aware of what it's going to take.
Well, and I think that kind of segues into kind of the ultimate benefit of establishing this kind of collaborative, this partnership relationship between spine and access, which is patient and realistically practice. They go hand in hand. Patients do well, practice does well. Patients do poorly. It's hard to argue that that's not going to catch up at some point in time.
Yeah, I think it's safe to let the patient outcomes drive everything. Takeaways from this conversation, most critically from me, are that this relationship is vital to establishing an anterior lumbar practice. If you dabble in it, it's also vital. But my guess is if you start to develop a relationship, whatever you're doing right now, it's going to double, it's going to triple, you're going to do a lot more, which maybe that's what you want to do. And I'd be surprised if you didn't find more success and enjoy that part of the procedure. Everybody loves an ACDF. There's a reason. Everybody loves a good ALIF also, and there's a reason. They're very, very similar. So there's a lot more complexity associated with the anterior lumbar approach, and a lot of stuff that you need help with. So I encourage you to reach out to your access surgeon, sit down with them, talk about it. It's going to take some stretching on both sides. We both had to stretch to make this work, but getting comfortable working together and sharing the patient is really what it's about.